This is online training outreach, ONTRO. We are using learning management system to expand the learning frontier and helping primary healthcare policymakers, managers, and care providers learn, perform, and report. Join us on ontro.ihstrategies.org. You are welcome to online primary healthcare lecture series. The title of this lecture is Primary Healthcare Development in Nigeria, Historic Visions and Milestones, and this is Session 3. My name is Dr. Mohammed Jibril Abdullahi. I am the ONTRO coordinator and the principal instructor. Reminder on issues in Section 1 and 2. Recall that Section 1 and 2 on PHC development in Nigeria, historic visions and milestones focused on 6 subject areas. These were the Basic Health Service Scheme, the PHC paradigm, the National Health Policy, the devolution of primary healthcare to local governments, the 1991 PHC review by the World Health Organization, and the operational reform towards the World Health System. We are starting this 3rd session with strategic institutional reform. Now let's look at strategic institutional reform. Strategic institutional reform is the 7th historic vision and milestone. There was organization and institutional reform which successfully resulted in the merging of National Primary Healthcare Development Agency and the National Program Organization (NPI) in 2007. This was meant to create a resilient primary healthcare system. The National Primary Healthcare Development Agency and the National Program Organization were separate entities until 2007, when the 2 agencies were merged through a presidential directive. Prior to this development, concerns were raised by stakeholders over the overlapping roles of the 2 agencies and the attendant competition for resources, space, and attention. The merging has resulted in the creation of a much more robust organization and deepened the stewardship role of the agency in the development of primary healthcare. In addition, internal alignment and realignments have also taken place to position the agency for greater efficiency in the discharge of its mandate. Now let's look at the PHC governance. The PHC governance reform is the 8th historic vision and milestone. The PHC under one roof governance reform has led to the establishment of several independent and financially autonomous state PHC development agencies with full responsibility for the overall funding and the resource management. Under the reform, the responsibility for primary healthcare operationalization and implementation still remains with the local government, with the federal and state governments through its structures and institutions providing overlapping, strategic, technical, and operational support. The federal support is explicitly provided by the federal government through the National Primary Healthcare Development Agency. However, the situation at the state level is characterized by multiple ministries, departments, and agencies, such as the Ministries of Health, local government, the Local Government Service Commission, and in some cases, the Governor's Office through Special Assistant for Primary Healthcare, all with overlapping roles in the development of primary healthcare. Such governance system, characterized by multiple lines of responsibility, constitute significant fiduciary risk and breed inefficiency. It also creates multiple PHC entry points in the state and confusion in program implementation, while the local government health administrations often are at the mercy of multiple interest groups. The development has been observed to constitute serious challenge to primary healthcare development in Nigeria. Consequently, the introduction of a PHC governance reform tagged Primary Healthcare Under One Roof initiative is seen as an attempt to address the challenge. The PHC governance reform is based on the principle of 3 1s, that is, 1 management, 1 plan, and 1 monitoring and evaluation. It aims at bringing all PHC activities implemented by all ministries, departments, and agencies in the state under an independent and financially autonomous state primary healthcare development agency. This SPHCDA has full responsibility for the overall funding and human resource management, while the local government PHC departments transform to local government health authority under the state PHC development agencies. Now let us look at the issue of multiple special intervention projects. Multiple special intervention projects can be grouped together to constitute the 9th historic vision and milestone towards building a solid PHC system. Nigeria has never lost sight of the need to build a strong and resilient healthcare system through a number of special intervention projects. Now let's look at some of these projects. Some of note include the Bamako Initiative and the PTF Intervention of 1986, the World Health System PHC Infrastructure Expansion Project that started in the year 2000. The Millennium Development Goals Special Interventions and the Conditional Grant Schemes, the Midwife Service Scheme of 2009, the SURE PMCH Project of 2012, and the Unending National Assembly Special Constituency Intervention Projects. What is common to these projects is the lack of sustainability. This will be subject of discussion sometime, somewhere. Now let us look at the National Health Act. The National Health Act is the 10th historic vision and milestone of the country towards building a sustainable health system. After a weary some journey of close to a decade, Nigeria finally has a political legal framework for regulation of its health system. Though the Act is not about PHC alone, the benefit to primary healthcare system is extraordinary. There are direct primary healthcare related provisions which, to a large extent, will facilitate the strengthening of the PHC system. The Act recognizes primary healthcare managerial process, that is, the village and the World Health Systems. The Act also recognizes the community resource persons, that is, the traditional birth attendants and the village health workers. Both are regarded by the Act as part of the formal health system. The Act also provides for creation of the Basic Healthcare Provision Fund. It also provides for the creation of state PHC development agencies as a precondition for accessing the Basic Healthcare Provision Fund. The federal government, nay, the Federal Ministry of Health and MPHC, must avoid the temptation of using the fund for direct implementation. Rather, the operation of Basic Healthcare Provision Fund should be based on the principle of being strictly a financing instrument and not an implementing entity. We must recognize that the LGA is the operational level for primary healthcare implementation, and it is at this level that all resources, including the Basic Healthcare Provision Fund, must be pooled and targeted for effective primary healthcare implementation. The most critical challenge will be the implementation of the Basic Healthcare Provision Fund. This will be a subject to another discussion sometime, somewhere. Now let's look at the current realities. The PHC was birthed in Nigeria in 1986, and this year marks the 31st year of primary healthcare implementation. The primary healthcare system consists of all the organizations, institutions, resources, and the people whose primary purpose is to deliver primary healthcare through a combination of public health actions and the pyramid of health facilities. While Nigeria cannot be said to be a total failure in PHC development, as remarkable progress has been made in several fronts, there are significant challenges. We must note the existence of a PHC framework in Nigeria. The commitment of the government towards institutionalization of primary healthcare in Nigeria is not in doubt. The organizational, institutional, and the management, infrastructural, and programmatic framework required for sustaining primary healthcare are firmly in place. This includes the policy instruments, the national health policy, which is already discussed, the strategic plans, which was derived from the national health policy, the legislative framework in form of the National Health Act, and numerous guidelines, standards, and protocols. There is also existence of institutions such as the National Primary Healthcare Development Agency and similar organs such as the state PHC development agencies and the local government health authorities. There are also infrastructure, an extensive network of over 30,000 public service delivery points. All this reaffirm that the country has sufficient organization and policy framework for better health for the Nigerian people through primary health care. Now, what are the key challenges? The key challenges in these areas are as follows. Overriding vertical approach in which immunization and other selective programs like malaria, HIV, AIDS, etc. can be said to be overriding PHC fundamentals. There is also the dwindling PHC content, the know-hows, the skills and competencies at all levels. And there is the disconnect between the PHC leadership and management and the concepts and core values underlying the primary healthcare philosophy. There is a disconnect between policy and practice of primary healthcare. If we look at the infrastructure and access to health services, we will note that to improve access to quality care and promote utilization of health services so as to impact positively on the health status of the population, adequate and functional infrastructure is required. However, despite considerable investments, availability of functional health facilities presents significant obstacles with the majority not functioning at optimal capacity in providing quality care, especially at the LGA and the ward level. There are indications that the health facilities often show decaying infrastructure and do not offer all the basic health services. Many health facilities do not have the required number of health personnel, the equipment, the supplies, and pharmaceuticals needed to effectively deliver services. Now, let's look at the outcomes. Health indicators in Nigeria are among the worst globally. This is not surprising since primary healthcare is the driver of national health outcomes and its strength mirrors the capacity of national health outcomes. The weaknesses in the system has impacted negatively on the service coverage, and the coverage rates for cost-effective life-saving interventions are considerably low. The coverage rates, particularly for maternal and child health services, are responsible for appalling maternal mortality. The maternal mortality rate is one of the highest in the world. Other health status indicators, such as the under 5 mortality rate, are higher than the average for sub-Saharan Africa. Life expectancy is also lower compared to other countries in the continent. While some progress was made towards the Health Millennium Development Goals, the country noticeably was off track. Nigeria has made limited progress in controlling targeted diseases, and the outbreaks of epidemic-prone diseases are common. These include measles, the yellow fever, Ebola, Lassa fever, and we are not done with polio eradication. Nigerians' usage rate of DOTS in detected cases is 18%, and this is low and is far below the global target of 70%. Adult HIV/AIDS prevalence rate has declined slightly to 4.4%, and we should note that there is high prevalence rate of malnutrition. Conclusion. This year marks the 31st year of primary healthcare implementation in Nigeria, and it is not all roses. However, the country's attempt in building a sustainable PHC system has on record a number of significant historic visions and milestones. The choice of the title PHC Development in Nigeria, Historic Vision and Milestones, is therefore a strategic consideration. We are currently striving to reposition the PHC system for universal health coverage and need to understand that history is the best teacher. Consequently, it is essential to reflect on the past efforts and lessons with a view to avoid past mistakes for the good health of Nigerian people. Thank you very much.